Okay, welcome everybody again. My name is Pawel Kravczuk. I work in Krakow University Hospital and Jagiellonian University Medical College. Thank you for the invitation to present enhanced recovery after cesarean section. I don't know what's the Ukrainian rate of cesarean delivery, but in Poland it's rising and it's closely reaching 50% of all deliveries. And a global prognosis is that it will reach 29% in 5 years. So we should be aware that it's the common way of delivery. The first information about enhanced recovery after surgery comes from Denmark. Colorectal surgeon Henrik Kellet introduced the idea at the end of the 20th century, and then it followed with next approach and building up the enhanced recovery after surgery organization. They managed to decrease hospital stay time from 2 weeks to 2 days, having a similar effect, not generating much complications. This idea grew up, and in 2005, ERAS Society was founded, and there have been three pillars: pre, intra, and post-operative, focusing on different aspects of colorectal surgeons initially, but then it followed with many other fields in surgery, including obstetric patients. We got a statement from the United States of SOAP showing those elements of ERAC, enhanced recovery after cesarean. And this year, we are happy to have information on update on enhanced recovery after cesarean section. We must be aware that it's not for everybody. It's elective surgery with no complications, selected group of patients, and it requires education, both education of staff and also patients. We must be aware on the urgency of cesarean section, and this Lucas category is still valid for obstetric patients. Usually emergency category 1, we don't have much time, and we offer very frequently general anesthesia immediately for those patients, but any other grade, urgent, scheduled, and elective for sure, are relevant for introducing enhanced recovery. What I already said, that this year had lucky in ERAS in obstetrics, because there are 3 parts: pre, intra, and post-operative has already updated. They follow the grading system and recommendations, so they recognize quality of evidence rating and also recommendation strength that will be shown in the slides. Before cesarean section, we need to focus on education. It must be patient, family, and interdisciplinary approach to the team that will take care, including midwives, nurses, dietitians, physicians, and other wards, including rehabilitation and pharmacy, because it's a team approach to the patient. And if you work hard to educate those people, the outcome will be better. The patient education is important, and we do have many online materials available, even in Ukrainian language. This comes from United Kingdom. The second comes from the United States. And I do encourage to visit those places and provide information for your patients on different ways of delivery, including a vaginal delivery and also cesarean section. The guidelines focus on antenatal preparation, and we need to focus on comorbidities and optimize patient status. Think about preparation and reducing risk infections before. So the night before and the day before, we should think about proper skin antiseptic preparation using chlorhexidine is the best way. We got also recommendation on pre-operative fasting, and it's a big part, and anesthetists should be aware of it, that emptying of the stomach with obstetric patients is similar to non-obstetric patients. So they should be allowed to have a light meal up to 6 hours before surgery and clear fluids up to 2 hours before surgery, because there are no increased risk of complications, but these patients feel better. It could be not even the dedicated fluid, it could be apple juice, so the non-particulate carbohydrate drink containing also the energy for those patients for the peri-operative period. What we know that these patients who are allowed to sip till sand to the operating theater feel better, have less thirst, less nausea, feel better in terms of the anxiety, comfort, and lightheadedness. This study does not show that the vasopressors use was lower. However, I'm sure that we will soon hear more about it, that there is another benefit. What we need to be aware that the aspiration is still a risk in terms of the general anesthesia. So we should be following the other guidelines. And here I show the OAA-DAS guidelines, focusing on pre-theater preparation. So assess airway, fasting status, and use antacids, including proton pump inhibitor or prokinetic drugs like metoclopramide. If there is elective surgery, those drugs should be considered in order to decrease the risk of aspiration. Those patients who have cesarean delivery are at risk of wound infection, so prophylactic antibiotic should be offered them, and usually is a first-generation cephalosporin adjusted to the weight of the patient to be introduced intravenously 60 minutes prior to skin incision to have the highest concentration possible at the beginning of surgery. Those unscheduled cesarean delivery should be considered with high and strong recommendation azithromycin, because usually the wound infection rate is higher, and there is a special population of obese patients, then we could consider adding another antibiotic and consider prolonging administration up to 48 hours. More about abdominal and vaginal preparation, abdominal chlorhexidine-based preparation and vaginal either chlorhexidine or povidone iodine solution, especially those patients with ruptured membranes. However, that might be offered for non-ruptured membrane patients as well. The guidelines have a strong, however, very low quality of evidence supporting personal support during surgery, so the partners should be allowed to be in the operating theater. I know it's not easy decision to be made, especially when the staff is against, but there is no increased risk for or any fields. However, we should promote gentle cesarean and promote well-being of the patient, also promoting early skin-to-skin for increased rate of breastfeeding and smoother postnatal adaptation. Intraoperatively, we should consider antiemetic drugs. What we are using usually is dexamethasone and ondansetron, secondary to drugs I have already mentioned, and dual therapy has a strong recommendation. We should prevent hypotension, and it's related to up to 80% of spinal anesthesia for cesarean delivery. Co-loading with crystalloids and vasopressors infusion started simultaneously to the beginning of spinal anesthesia. What I already said, that up to 80% of elective cases has a challenge like that, secondary to the decreased sympathetic tone with spinal anesthesia, and also pressure that might be done by the gravid uterus, closing the lumen of big vessels and impairing preload for myocardium. So consider release of autocaval compression, and also start with crystalloid co-loading, and consider drugs that will squeeze the vessels, so increase the peripheral resistance. 3 drugs are mentioned here, those who are present in the current literature. If you are working in the Western countries, probably phenylephrine is the first choice drug, especially in the UK. However, other European countries, including Western countries, consider switching to noradrenaline, and this is something what we are using now. It is safe and effective. It has intrinsic beta agonist effect, so there will be no bradycardia, which is a challenge with phenylephrine, especially when you consider boluses of phenylephrine. I think that majority of hospitals have access to ephedrine. However, it's not the best option for maternal patients and babies, because generate maternal tachycardia already present if hypertension is present, and influence neonatal outcome in terms of the Apgar scores or pH of the cord blood. We should pay attention to normovolemia, normothermia, and optimal use of uterotonic agents. What I already said before on uterotonic is still valid here. So oxytocin, first line, or carbetocin. If you need something more, consider second-line treatment, methylergometrin, misoprostol, carboprostol, sulprostone. Consider to have those options available, especially in case of risk or present uterine atony. Multimodal analgesia, that is something that we should adopt. I don't know whether it's popular in Ukraine to use intrathecal morphine, but it is a high level of evidence and strong recommendation. It's very uncommon to have such a supportive treatment, and it is recommended to use it with spinal anesthesia. Also including non-opioid drugs, acetaminophen and NSAIDs. Usually we use ibuprofen, and we start this treatment during surgery after extrication of the baby. Dexamethasone decrease the needs for other analgesics. We use it with a dose of 8 milligrams. The guidelines says 6 milligrams at least. And supplemental local blocks are usually not needed if intrathecal morphine is used. We should be aware that there is a risk of apnea with any opioid given, regardless the way we are administering it. However, low doses of morphine and fentanyl are safe. And we need to look at the pharmacokinetics, because fentanyl has a short onset of action, but the duration is also not too long. After 6 hours, usually it's not present. But this is a time when morphine is active and gives a prolonged activity up to over 30 hours, which gives a fantastic effect for patients. And those patients who have 2 cesarean deliveries with and without spinal anesthesia, morphine, because we started to use it a few years ago, just ask us what has happened. It is so effective. Respiratory depression was first described a long time ago. It's over 40 years ago with the first cases, but the doses were very, very high, 5 milligram given. However, were case reports without any side effects of 20 milligrams doses. When we look at the literature, there is a statement of Society of Obstetric Anesthesia and Perinatology, which is covering also and recognized by American Society of Regional Anesthesia. It is more than 5 years old, introducing a low dose and ultra low dose morphine spinal administration. If it is an ultra low dose, up to 50 micrograms spinal or 1 milligram epidural, no extra monitoring is required here. As I'm aware with, we are expecting European Society of Regional Anesthesia statement, considering even higher doses to being safe. Just to compare the doses between spinal and epidural, because many obstetric patients have a labor epidural and prolonged need for treatment pain after laceration or injury during delivery. We could also consider low dose of epidural or spinal if used morphine for benefits for those patients. As I already mentioned, it's a strong recommendation with a high level of evidence, also covering non-steroid inflammatory drugs and paracetamol. It has been also introduced many years ago from now with a prospect guideline for treatment pain after cesarean section. You must be aware that it is dose related. To be sure that you give no more than 50 micrograms, you need to titrate drug and use insulin syringe compared to the regular one. When you look at the left side of the slide, the dead space of the regular syringe and the regular needle contains more than you want to give in a spinal space. So you can easily double the dose when you use the regular syringes. That's why for titrating this drug, we are using more insulin syringes for administration of morphine spinal. Or, as already mentioned, additional peripheral blocks like TAP or quadratus lumborum block may be beneficial for those patients, those obstetric patients who did not receive morphine spinal, so mainly general anesthesia patients, when we have time to ask the patient on permission of those blocks. After delivery, after cesarean delivery, we need to mobilize patients early, allowing him to drink and eat early. If there is no problem with nausea, vomiting, and patient is happy to drink, 1 hour is enough to allow them. So we early discontinuate intravenous fluids mobilize them early, usually 6 hours after surgery. They are allowed to sit and walk under the supervision of the staff. We remove urinary catheter very early if there is no problem with urination, and follow with scheduled regular doses of acetaminophen, so paracetamol, and non-steroid anti-inflammatory drugs. Morphine spinal really decreased demand for any extra opioids given. However, you need to have a protocol of rescue opioids. Oral way of administration is preferred. And usually a very, very low dose, and it's uncommon to follow it this way. We also have an approach to standardized rescue medication for nausea, vomiting, pruritus, and shivering. And also, if respiratory depression, the protocol should be ready for that, and follow recommendation of venous thromboembolic prophylaxis. Mechanical, but most of the patients after cesarean delivery also meets criteria for pharmacological treatment. Usually we administer first dose 6 hours after cesarean delivery. This meta-analysis shows the ways of treating pruritus on small doses of propofol, small doses of opioid ago antagonists, so nalbuphine could be considered. Ondansetron has this activity. If nothing is effective, consider naloxone as an opioid antagonist. However, we must be aware that the desired opioid effects are also needed. Just mentioning the document because some patients struggle after cesarean delivery with postpartum post-dural puncture headaches. There is a ready-to-use protocol, and I encourage you, it's open access protocol to follow. We don't have any major ways to avoid post-dural puncture headache, but there is a good way for treatment, and many of those patients has release of symptoms quite early. We need to focus also on post-operative anemia. I have already addressed this topic with my previous talk, and think about iron supplementation. Usually, transfusion is not needed with patients with hemoglobin level more than 7 grams per deciliter. If they are asymptomatic, I created the way of assessing symptoms of hemodynamic instability for my obstetric colleagues. So if the patient meets the mentioned here criteria, that's the patient that probably needs transfusion. Even if stable and not bleeding, we need to think whether there is a need for hemoglobin supplementation or not. If they are not present, we could just go on and wait until the iron supplementation is effective. Also, the scale that I was mentioned in my previous talk, so early warning scores, just to monitor the patients and recognize those who are at risk, and find a proper solution, whether there is a problem with volume, problem with muscular resistance, or any other issue that triggers the call criteria. We should support breastfeeding, so encourage again early skin-to-skin contact. It would be great if the patient receives her baby right after delivery and the contact is continuous. So we should have a dedicated staff taking this part of support and to evaluate their work and think what we could do better to promote breastfeeding. We also should cluster our intervention not to disturb too often those moms, to prevent and promote rest of those patients and facilitate patient-centered care, just informing them, giving a checklists at discharge, informing what they should turn if help is needed. It would be great if it is provided to them in the preferred language. In Krakow, we have many foreign patients for different reasons. And we do have a challenge, and the information I provided on the website on international access, not only our national languages, are free to use and to be shared with patients. I'm sure there will be questions, so I will try to connect for questions and answer sessions. And just to summarize, the ERAC protocols, enhanced recovery after cesarean, reduce the length of stay, improve outcome in terms of the pain and quality of recovery without increasing complications and rates of readmissions. So we should optimize maternal postpartum experience, satisfaction and recovery using these protocols. Majority of them just need to be introduced because we have access to many of those interventions. However, everybody should be aware of it and educated in a proper way, including patients, their families, and hospital staff. Thank you for your attention.